Hi guys, so today we are going to learn about a few diseases of the respiratory tract, including atypical pneumonia, tuberculosis, and inhalation anthrax. All three of these diseases are bacterial diseases. Before we begin talking about the selected respiratory diseases, I wanted to start out with a brief review of the anatomy of the respiratory tract, so we can keep in mind where exactly in the body these disease processes are occurring, and the overall pathway a pathogen travels once it is inhaled. Beginning with the upper respiratory tract, we can see the upper airways, the nasal passages, the oral cavity, the pharynx, and the larynx. When you inhale through the nose, for example, that air travels through the nasal cavity, into the nasopharynx, then through the oropharynx and the laryngopharynx. Once the air passes under the epiglottis and into the trachea, it has reached the lower respiratory tract, which includes the trachea, which splits into the right main bronchus and left main bronchus, which splits further into bronchioles, terminal bronchioles, alveolar ducts, and finally the alveoli where the actual gas exchange occurs. As the pathogens are passing through the respiratory tract, they encounter host defenses that try and prevent them from attaching and establishing infection. In terms of innate immune responses, we have a lot of mucus lining the tract, as well as the mucociliary elevator, which involves the pulsing upward motion of the cilia, physically sweeping mucus and trapped pathogens to where the human can then swallow it or cough it up. There are also alveolar macrophages that function in phagocytosis, neutrophils which can engage in phagocytosis and also direct killing of pathogens, and other innate immune defenses in the lung include complement alternative pathway and also draining lymph nodes. In terms of adaptive immune defenses, which are more specific, this involves actions by your B and T cell lymphocytes. In your upper respiratory tract, secreted IgA blocks attachment. In your lower respiratory tract, IgM and IgG in serum in the alveolar lining fluid functions to activate the classical complement pathway. In addition, IgG acts as an opsonin to promote phagocytosis. Also, your T-cell lymphocytes are going to function to help fight viruses and other intracellular pathogens. Keep these host defenses in mind as we talk about disease mechanisms of each respiratory pathogen and how the pathogen is able to overcome these host defenses in order to cause an infection. Atypical pneumonia, also called walking pneumonia, is a bacterial infection that primarily affects the lower respiratory tract. The causative agent of atypical pneumonia is predominantly Mycoplasma pneumoniae, and although we are going to be focusing on atypical pneumonia caused by Mycoplasma pneumoniae in this presentation, it is important to note that other bacteria can also sometimes cause other forms of atypical pneumonia, including Legionella and Chlamydophila. The term atypical means that the pneumonia can affect more than one organ system, that the white blood cell count is typically normal, and that the symptoms are generally mild and gradual and are similar to an upper respiratory tract infection when they first present. Mycoplasma pneumoniae bacteria lack peptidoglycan and therefore do not have a rigid cell wall. They usually occur in a filamentous form. Interestingly, they are the small species of bacteria that is capable of growing independently. The small size is advantageous because it allows the bacteria to actively avoid and slip through bacterial filters, remain undetectable by light microscopy, and also avoid identification via liquid growth medium because it is simply too small to create a turbidity that we can actually see. It is typically an extracellular pathogen, although as we will see later, it sometimes can enter cells and reproduce. A very important feature of this bacteria is that it has a special attachment organelle that allows it to attach to host cells very tightly. In the picture on the right at the arrow, you can see a Mycoplasma pneumoniae bacterium using its attachment organelle to tightly adhere to a respiratory epithelial cell. Although the exact disease mechanisms and pathogenesis of Mycoplasma pneumoniae is still being investigated, some disease mechanisms are known. Transmission is through droplets, but because they do not have a cell wall, they are very sensitive to desiccation, and so that it needs to be transmitted from person to person inhaled very directly. Portal of entry are the nose and mouth. After inhalation and entering the human respiratory tract, it uses its attachment organelle with adherence proteins to adhere to respiratory epithelial cells. The adherence is so strong that the human mucociliary elevator is unable to sweep the microbe out, allowing the bacteria to avoid the innate host defense. Once securely attached, the bacteria starts to damage the epithelium, especially the cilia, causing damage to the function of the mucociliary elevator. This bacteria is typically thought of as an extracellular pathogen, but sometimes it is able to infect and subsequently reproduce within the host cells, which may allow for chronic infection, further evasion of extracellular host defenses, and dodging of drugs that destroy the bacteria. In addition, Mycoplasma pneumoniae has a characteristic virulence factor called community-acquired respiratory distress syndrome toxin, which causes an inflammatory response and helps the bacteria colonize the respiratory tract. This exotoxin causes the cilia to lose their ability to move, further overcoming the mucociliary elevator. This exotoxin also causes the creation of free radicals that causes further damage to host cells. The infection is usually very mild. In uncomplicated atypical pneumonia, symptoms include fever, sore throat, dry cough, sweating, chest pain, chills, shortness of breath, and fatigue. When complications do occur from a very severe form of Mycoplasma pneumoniae lung infection, these include asthma attacks, encephalitis, and hemolytic anemia. Usually, the diagnosis of atypical pneumonia by Mycoplasma pneumoniae may be made on clinical presentation of signs and symptoms alone. Chest X-ray can screen for pneumonia but will not identify the causative microbe. Diagnosing these infections is typically difficult for several reasons, including difficulty obtaining samples from the lower respiratory tract, and, although it can grow regardless of whether oxygen is present, it is considered to be fastidious, or rather particular about its nutrient requirements, and the culture results aren't available until 3 weeks later. Since it is resistant to beta-lactam antibiotics, the benefit of identification is that appropriate antibiotics can be given. However, macrolide antibiotics are usually provided based on the patient's clinical presentation and serology results alone. Because Mycoplasma pneumoniae bacteria do not have peptidoglycan, they are resistant to antibiotics who act on cell walls, such as beta-lactam antibiotics like penicillin. Alternative antibiotics are given, such as macrolides, fluoroquinolones, and tetracyclines, depending on the patient's age. Atypical pneumonia is not a reportable disease. Mycoplasma pneumoniae infections are actually pretty common, and since there is no system in place to track cases of it, the actual incidence, prevalence, and other epidemiological statistics are unknown. However, the CDC estimates that in the United States, there are approximately 2 million new cases of these respiratory infections every year. Environments in which it is more likely that there will be an outbreak include those that are crowded. Prevalence is also underestimated. This is partially due again to atypical pneumonia not being a reportable disease, but also because most patients tend to not show severe symptoms, and the disease is typically so mild that the majority of individuals do not seek medical attention for the infection. Atypical pneumonia caused by Mycoplasma pneumoniae is actually one of the most common causes of community-acquired pneumonia. The next disease of the respiratory tract is tuberculosis. There are two main forms of TB: latent TB, in which you are infected but are not actively sick, and active TB disease that needs treatment and is contagious. Tuberculosis is considered to be a form of chronic pneumonia. Mycobacterium tuberculosis is a type of actinobacteria. It has thick membranes consisting of mycolic acids, arabinogalactan, and peptidoglycan, which form a waxy coat that helps protect the bacteria. Although they have peptidoglycan, so are technically gram-positive, they do not gram-stain because of the large lipid content of the cell wall. Acid-fast staining needs to be performed instead. The only reservoir for Mycobacterium tuberculosis is humans. These bacteria are non-motile, obligate aerobes, and are acid-fast bacilli. Once the droplets are inhaled, the bacteria travel to the lungs, where they are engulfed by alveolar macrophages. They survive and replicate within the alveolar macrophage, living in a modified phagolysosome, as the microorganism prevents phagosome and lysosome from fusing normally. A delayed type 4 hypersensitivity reaction ensues, which prevents the spread of TB, but also allows the TB bacteria protection and containment. Granulomas form, encircling the infection. The tubercles become caseous lesions, which can then become a bone complex, which can be seen on an X-ray. Ultimately, the bacteria are either destroyed and cleared, or trapped within the body, becoming latent TB. When able to overcome host-immune defenses, they can cause primary active TB disease. Secondary reactivation tuberculosis occurs when the latent TB form is reactivated later, even years later. This occurs most easily in an immunocompromised host. Another distinction is miliary TB, which occurs when the bacteria disseminate into the bloodstream and then form abscesses throughout the body. Latent TB, the inactive form, has no signs and symptoms, and the patients are not contagious. Symptoms of active TB include productive cough that produces sputum, coughing up blood, fever, no appetite, sweating during the night, weight loss, and fatigue. These patients are contagious. In order to tell if the patient has active and contagious tuberculosis, it is necessary to amplify the M. tuberculosis DNA from the patient's blood sample and visualize the bacilli within a sputum sample. Culturing the patient's sample of sputum is the primary way to confirm a diagnosis of tuberculosis. Diagnosis of TB includes cultures using the acid-fast staining method. The MAN2 tuberculin skin test, which is based on a delayed type 4 hypersensitivity reaction, interferon gamma release assays, nucleic acid amplification testing, and chest X-rays. The skin test and interferon gamma release assay do not tell you if the TB is latent or active and contagious. Treatment for tuberculosis depends on the patient's individual case. However, usually a therapy of 4 drugs is provided, including rifampin, isoniazid, ethambutol, and pyrazinamide. Tuberculosis is a reportable disease. The incidence or number of new cases each year has decreased overall, with only 9,105 new cases of TB in 2017. TB has been found to exist in all 50 states, with the largest prevalence in California, Texas, New York, and Florida. The mortality rate actually increased between 2015 and 2016. Risk factors include travel, being born in a country where TB is common, diabetes, HIV, homelessness, and excessive alcohol use. Only about 10% of people who have a healthy immune system and have been exposed to TB will actually develop TB. This risk increase for those who are immunocompromised, meaning that tuberculosis is an opportunistic pathogen. There is also a multi-drug resistant form of tuberculosis emerging that infects not only those with immunocompromised conditions, but is also significantly infectious to healthy individuals too. Multi-drug resistant forms are resistant to 2 first-line drugs. Extreme drug-resistant TB also exists, which are resistant to over 3 second-line drugs and 2 first-line, making such cases extremely hard to treat. Our third respiratory disease is inhalation anthrax, also deemed wool sorter's disease, which apparently came about after some individuals got inhalation anthrax infections after working in an enclosed factory working with animal hides and wool. It is caused by Bacillus anthracus bacteria. Bacillus anthracus is a gram-positive, aerobic, non-motile, and spore-forming bacteria. The spores can remain in soil for years and then proliferate once they have ideal conditions in human host tissues and blood. Unfortunately, this bacteria has historically been used as a biological warfare agent, when the spores were mailed in letters to different individuals. Before these attacks occurred, it was only thought to be a potential risk in certain types of factory work, such as wool mills and slaughterhouses. It has now been designated as a Category A highest risk agent as it is easily disseminated in bioterrorism. Bacillus anthracus is transmitted via the inhalation of spores, and thus the portal of entry into the human host is the nose and mouth. Overall, it begins in the chest lymph nodes, and then is able to spread throughout the body, causing both respiratory complications and shock. An important disease mechanism of Bacillus anthracus is that it secretes an AB anthrax exotoxin, which allows it to cause damage to host cells, which is what makes anthrax so lethal. In general, an AB toxin is one that has an active component A and a binding component B that helps with the delivery of A into the host cell. In the case of anthrax, once the B subunit helps give the A components access to the cell via an endosome, edema factor binds calcium and calmodulin, forms adenylate cyclase, which causes an increase in intracellular CAMP, ultimately leading to an efflux of water and interstitial fluid, causing edema. Lethal factor is a protease enzyme that damages mitogen-activated protein kinase, ultimately causing host cell death. These two A components cannot act at the same time, however, because the B component can only bind one type of A component at a time. It is also important to note that the B component is also designated as protective antigen, because antibodies to this subunit help to try and protect the hosts from disease. The prodromal phase of inhalation anthrax is typically 5 days, and the individual will present with symptoms that appear flu-like or similar to a common cold. It is important to get a good patient history to determine if exposure to anthrax was possible, so antibiotics can be given, because the individual, once exposed and the symptoms present, can actually die within 48 hours. Symptoms include fever, muscle aches, weakness, shortness of breath, coughing up blood, drenching sweats, confusion, and nausea. Diagnosis of inhalation anthrax involves cultures and serology, analyzing blood samples for the antibodies and the anthrax toxin, and analyzing blood, respiratory secretions, and spinal fluid for the bacteria. It is important that the samples are collected before the patient is treated with antibiotics. Once identified as inhalation anthrax, antibiotics can be provided, such as ciprofloxacin and doxycycline. The vaccine is also available as a preventative measure. Anthrax antitoxin to the AB exotoxin can also be provided. Fortunately, inhalation anthrax is very rare in the United States. It is more common in places like South America, Central America, Eastern Europe, Asia, and Africa. However, it is extremely deadly, and the mortality statistics are grim. Without treatment, 85% of the patients die. Even with aggressive treatment, only a little over half of infected patients live. Risk factors in addition to bioterrorism, including working with infected animals. I hope you guys all enjoyed my presentation on respiratory tract infections, and I will see you guys all in the discussion forums.